So, we had seen this when we were talking about prevalence rates. I actually had made note of this, though you may not remember, of course. But major depression occurs in about 16% of the population, and some studies actually show it going up to at least 20% of the population. Remember that it's episodic, so it's not that 16 or 20% of people are depressed at any one time, but that 16% of people will have a depressive episode at some point in their life, which is very different, right? It is more common in women than men, which is going to be a trend for these next, for many of the disorders in the next couple of chapters. Also more common among people in lower SES groups. And again, it's not that it's less common among the very wealthy, it's that it's more common among the very poor. And that goes back to the stressors and the effect of stress that we talked about in one of the early chapters. We do see a fair amount. I know some of you were interested in this topic in one of the earlier discussions, but this is one of those disorders where we do see variation across cultures. And I'm forgetting now what exactly, who asked this, but we do see this across cultures and that probably has to do with different levels of interconnectivity with family and social networks in different cultures. So for example, in the United States, we are much more likely, mainstream American culture, people living in mainstream American culture are much more likely to be distant from their families, geographically distant, and so people are more mobile in the United States than they are in some other countries. If we look at a country like Italy, for example, much more likely to get multi-generation generations of people living in one home, or people who, even if they're living away, maybe traveling back home on the weekends. So that they're young and they're living in a city, they go back home to the countryside on the weekends. And so the greater the social support, the lower the levels of depression that we see. But we also may get genetic variation across cultural groups, since cultural groups tend to be more genetically linked to each other, especially if they're living in homogenous cultures. In the United States, that's genetics is going to play less of a role in the difference among cultural groups all living here. But we also may see differences that are artificial, that are the result of different cultures using different diagnostic criteria. And so we may get differences in rates because of that. People who live further from the equator are also have higher rates, and so those Northern European countries, and essentially that probably has to do with how many days a year we have adequate sunlight. And then like fish diet, so people who live near water and eat lots of fish seem to have lower rates of depression, and it's not clear whether fish diet's causing that or whether that is an illusory correlation where it's really about what cultures are like who have high fish diets, and that there's other factors, not the diet itself. One of the important things here is that depression has a very high co-occurrence rate with anxiety disorder. So almost 2/3 of people who have depression also meet criteria for at least one anxiety disorder. And anytime we have co-occurrence that's that high, then we really are going to be looking at whether there's similar genetics that are dictating both of those disorders, and also whether there's similar neurobiological processes, brain processes that are in effect in both disorders. And as you'll see, we're going to talk a little bit, for example, about the amygdala as one brain area that's important for mood disorders, and we'll talk a lot about the amygdala as a brain area that's very important for anxiety. And so in that way, if you have a disruption to how the amygdala is functioning, you may be at risk for both sets of disorders. So it's not that one disorder is necessarily causing the other. It's probably that a third factor is important in the development of both of them. And then, like, when we think about depression, I think, unfortunately, because we use that word with a small d as well as with a capital D, so we use depression to just describe mood fluctuations as well as to talk about a disorder, many people minimize how important or how significant the experience of depression can be. And what most people focus on, if they are concerned, is on that suicide risk. And as we said in an earlier slide, suicide is something to be concerned about, obviously. But not everyone who is depressed is suicidal by any means. And not everyone who is suicidal is depressed. And that's an important thing to pay attention to. And we're going to talk a number of places for the rest of the semester about the role of hopelessness, that people are likely to become suicidal when they feel hopeless, when they feel like things cannot change and get better. And in some ways, right, knowing that major depression is episodic means that if you understand that, then you're likely to believe it will get better. However, hopelessness is also a symptom of depression. It's an experience that comes with depression, so that does raise the risk of suicide simply because you're more likely to feel hopeless. But there are other, so in a second we'll talk about the fact that persistent depressive disorder, because of the persistent nature of it, is actually more likely to engender hopelessness than a major depressive episode is in some ways. But it is, suicide risk is a consequence of major depression, and so we need to always have that in mind. But the thing people are less likely to think about is how disabled people with depression are likely to get. And so lots of people who have significant depression are either unable to work at all, and so they go out on disability, or they quit their jobs or get fired from their jobs for being unable to do them. Or if they're not employed, right, disability is also about child care and self-care and other roles that we're supposed to fulfill, friendships. And so we do get disability from depression with those as well. And so even if somebody can work, they're likely to not be as valuable an employee because of lost productivity, and they may or may not get fired. But even if they don't get fired, they're less likely to get promoted, they're less likely to get raises. And so these kind of long-term, more diffuse consequences of depression start showing up. If you're depressed, you may be less likely to date, or at least not to date successfully, and so you might be less likely to form permanent relationships. You may be less likely to make new friends or sustain old friendships, right? So there's all of these ways that major depression, the symptoms of major depression, can really shape life in some not so great ways. And then the last of these is that people with depression are more likely to have significant health issues. So they're more likely to have things like hypertension and or high blood pressure, and diabetes, so on. And that's about neglecting their health. That lots of the people I see who come to me and they've been depressed for a while often haven't been to the doctor in a while. It takes a lot of energy to make an appointment. It takes a lot of energy to go. If you're feeling worthless, or not feeling good about yourself, you may not want to put yourself in the position of being under scrutiny in that way, and so they're more likely, people who struggle with depression are more likely to have those kinds of health problems. Persistent depressive disorder occurs at much lower rates, and so one trend that you and I will talk about and that you can pay attention to as we move through these chapters on diagnostic categories is that more chronic conditions, so episodic major depression versus persistent PDD, the PDD is more chronic, more ongoing. More chronic conditions happen at lower prevalence rates and more severe symptomology, more disruptive, I should say, symptoms. So like the symptoms of schizophrenia, for example, or the symptoms of bipolar disorder, as we'll talk about in just a moment, those that are more disruptive, also tend to happen at lower prevalence rates. So here, persistent depressive disorder, much less likely to occur, much lower prevalence rate than major depressive disorder, and that makes sense in terms of the chronicity of this. But people with PDD are more likely to be hospitalized at some point in their life for this psychological disorder. They're more likely also to become suicidal because they're more likely to experience hopelessness, right? They've been feeling this way for years and they don't have an expectation that it will get better. They also have more impaired functioning because of the chronicity. So even though their symptoms are not as significant at any point in time, if you've had an employee, for example, who's always had low productivity, as long as you have them in your employ, you might be more likely to fire them. You might be less likely to give them a raise or a promotion compared to the person who's normally been very productive, and in the last 6 months you've noticed they're not very productive. You might see it as a blip, right? Which is what it is, an episode of major depression. And so you're thinking, so in that way, thinking about the kind of the impact of the ongoing symptoms and the effect of hopelessness and functioning in that way. So we're going to pause there, and the next video will more closely examine the manic disorders.